Thanks for being with us again. I'm Harry Greenberger, host for this show, and today we're going to be talking about a very important topic. Our guest today is Noel Twilbeck, who is the Chief Executive Officer of No AIDS Task Force. And I want to welcome you to our show, Noel.
Thank you.
And why don't we just, let me just say that I did get some information about your organization from your webpage, and it says your mission is to reduce the spread of HIV infection, provide services, advocate empowerment, safeguard the rights and dignity of HIV-affected individuals, and provide for an enlightened public. That's a big project. Why don't you tell us first how you became involved with No AIDS Task Force, and then we're going to talk about what you're doing.
Okay. First of all, thank you for having me on the show.
It's our privilege.
I became involved with the agency 20-something years ago as a volunteer. It was a time when people were getting sick, dying. We didn't know what from. We didn't even have terminology to describe it at that point in time. But it was because a friend had asked me to get involved on a personnel committee. I was working in human resources at the time at a local hospital. So even there, we started seeing some of the devastation of the impact of the epidemic as people coming into the hospital, and the fears and phobias that we had back then were pretty apparent. And
at that time, those people were dying.
The people became sick. We didn't know what it was from. They got into the hospital, and many didn't leave the hospital. It was also at a point in time when I was just coming out as a gay man, so it wanted me to rethink what I was moving into, or even the people that I were meeting. Many of them were becoming sick and dying, so it was quite a frightening time for so many people. But I became involved as a volunteer, and eventually came on staff of the agency about 20 years ago. I served as the volunteer director for probably about 12 years before moving into the position of director for the agency. I think the involvement, like many other people, it was out of seeing so many of our friends lost and people needing services. My first partner became sick, went in the hospital, and died, and afterward we found out it was related to HIV. So I think for many people in our communities, we didn't want to believe that HIV was going to impact our lives, but in some fashion, as we look out, there are people, our neighbors, our family members, our friends, people we work with are impacted by HIV.
We certainly had an eye-opening experience when we became aware that it was being transmitted, and it was often fatal.
Oh yes. And we've moved in time with HIV. In many respects, it's been a lot of good information, a lot of good science, a lot of good data. The treatment and therapies are vastly improved. We've moved from a time where people were finding out about HIV infection and becoming sick and dying, and it many times was a fatal disease, to now it's more of a chronic, manageable disease if we're able to get people into treatment. And that's a very important piece of the whole puzzle, is if we can get people into treatment, if they have access to medication and therapies, and if they're able to access that on a continuous basis.
Are you suggesting that there are people even today who may be HIV positive who are not going for treatment and not trying to preserve their lives?
What we've seen is across the country, we see about 40% of people that may be living with HIV that are not in active treatment.
And they know that they are HIV positive.
We have people that know they're HIV infected, not in treatment, and others that do not know.
Who don't know, they just know they've been sick. Is that?
Or they may not have been symptomatic or sick at all.
Okay. Oh, okay.
Or have never been tested. And I think part of it's hard to pinpoint the reasons why people might not seek care. And it's easy for any one of us to speculate on that, but in our day-to-day working, we see people dealing with a lot of complex and difficult situations where if a person's trying to make a decision with meager resources that they might have of whether or not they're going to spend their time and energy at getting their children into school or getting a roof over their heads or going to a medical appointment, when people are faced with those decisions, you understand why they may make decisions that might not bring them into care. That's kind of on an extreme. Other times we see people who don't want to get in care because they feel fine. They're not sick. We have other people who make decisions that they don't want to take medications because the medications themselves can be very toxic and can make people sick. There often are side effects that are very difficult to deal with. And we've got what we work on is working in adherence with individuals to try to get them to a point where they are making decisions based on good information as opposed to how they feel.
Now, the treatment, which includes, of course, medications and I don't know what else, but that can be very expensive. Now, No AIDS Task Force assists people in that respect, don't you?
That's correct.
How does that work?
Well, there are federal funds that many communities have, actually most states and territories have access to for medications for people living with HIV disease. And it's based on eligibility criteria, which would have a basis of income. So if a person is at or below, in Louisiana, at or below 400% federal poverty guidelines, they would be deemed eligible for many of the medications that address HIV itself.
You mean eligible for free? That they
yes.
would be.
Yes. Now, that being said, there's still some hurdles. Deeming the person eligible may present some hurdles for some people, but right now those medications are dispensed through our public health system. So a person would physically have to go down in New Orleans to a clinic at I think right now it's at the Lord and Taylor building. So there's there may be transportation issues around some of this, or if we can get either a case manager or a peer advocate to help with accessing the medication, we'll work with that. But it's not as simple as for many of Americans who have insurance, with a pharmacy benefit, you can go down to your local drugstore and get your medications. It's not quite that simple. There may be some barriers that are built into the whole administration of the program.
What if a person had an income higher than is allowable in this situation? What would it cost, say, per month for the needed medication?
I think an average cost is about $2,000 a month, and that's probably just for the HIV medications. If there are co-infections, if a person's on prophylaxis medication, it could be higher. So the cost of the medications are not inconsequential. And what we also see for individuals that might be just above that threshold of where they're eligible, they could have to make some decisions about whether or not they can continue working at that same income level. I mean, $2,000 a month.
That's a lot of money.
It could really take away from the ability of a person to pay your rent or to go to the grocery store. I did erroneously say something about the 400%. In New Orleans, we can access medications for people at 400% or below. For the rest of the state, it's 200% for our AIDS drug assistance programs.
Now, I was going to ask you, because I think no AIDS, does that mean New Orleans, the NO part of it?
The agency began in New Orleans.
Well, what territory do you cover now?
Right now, we provide services in 12 parishes in southeast Louisiana.
I see.
We have offices. We operate our programs out of 4 spaces, 4 physical locations in the New Orleans area and 2 in Houma, Thibodeau area.
You provide testing for people who think maybe I need to be tested. Is that one of your services?
We do. We have HIV antibody counseling and testing program where we offer testing at, I think, 6 days a week at 2 different locations.